Today we are going to discuss about management of cancer pain. Let us see the magnitude of cancer pain in our country. So you know that 80% of cancer patients in our country are diagnosed in late stage when there are already metastases in the different parts of the body. And these patients, 90% of them complain of severe pain which are not adequately managed. Not only pain, these patients have several other complaints. They have the difficulties in eating, they have weight sores, they have psychological issues, they have the spiritual issues. They ask question, why this happened to me? And we don't have any answers. They have financial problem, they have the social, the family problems. So altogether, it's very miserable conditions, and pain is most important, most significant out of all these components. So if you can manage pain significantly in these patients, we can give a significant relief and we can increase the quality of life in these patients. Now let us discuss with one such patient. This patient was a female patient of 62 years of age, complained of the back pain for last 1 year. This patient was a known patient of the cancer. Primary source of the cancer was not known, but when she presented, she was having metastasis in multiple bodies, iliac bone, psoas muscles, sacrum. Predominant pain was back pain, little more on the right side. But recently, for the last 2 months, she was also having the leg pain. And this leg pain was radiating down the buttock, thigh, posterolateral aspect of the leg, down to the sole, up to toes. This patient was unable to sit at most. When she is sitting, her pain is increasing terribly. When she is standing, pain was little relieved. And when she is lying down, only then she is having the significant pain relief. The leg pain is more or less constant. Whether he is sitting, whether she is standing, walking or lying down, leg pain is more or less constant. So when we saw this patient, we examined the patient thoroughly. We took the help of pain detector tool to assess the quality of the pain. The history of presenting illness was the pain was gradually increasing, pain was nociceptive in nature, the pain has significant relation with the posture, and this pain was partially relieved with analgesics, morphine and paracetamol. She was on paracetamol and morphine 120 mg. With that, she was having partial relief of back pain, but no changes of the leg pain. This patient was otherwise fit. Patient was having the normal liver function test, renal function test. Other physical examination was almost normal. Little bit anemic, otherwise no other abnormalities in the blood parameters as well. So seeing this patient, we started pregabalin and nortriptyline because this leg pain was predominantly neuropathic in nature. We started pregabalin at a dose of 75 mg 2 times a day and nortriptyline 10 mg 2 times a day, and with that her leg pain started reducing significantly. Very soon her leg pain was not there almost, but she continued to have the back pain. Back pain was still at a level of 6 out of 10. At this position, we decided to go for the intrathecal morphine pump, and for that we admitted the patient and went for a test dose of intrathecal morphine. So we went for a 1 mg stat dose. Normally intrathecal morphine test dose is given 0.5 to 1 mg, but here because the patient was already on 120 mg per day morphine, so we went for 1 mg stat dose of intrathecal morphine. And with that test dose, patient was having a very good pain relief, almost no pain for first 8 to 10 hours, and then pain gradually returned back over the 24 hours, but still was significantly less than the other time. So this was a perfect candidate for the intrathecal pump. and we implanted the intrathecal pump and started morphine at a dose of 1 milligram per 24 hours. This pump was a fixed mechanical pump, and here the flow was 0.5 ml per day per 24 hours. And our dose of the morphine was 1 milligram per 24 hours, meaning that the liquid which we injected into the pump was having a concentration of morphine of 2 milligram per ml, so that the patient is receiving 1 milligram of morphine per 24 hours. And with that, patient was having very good pain relief of both back pain as well as the leg pain. So back pain was managed mostly by the morphine, and leg pain was managed mostly by the pregabalin and nortriptyline combination. So if we are coming back about the different types of pain, we know that there are two broad types of pain. One type of pain is nociceptive, which is primarily relieved by the analgesics. This nociceptive pain is because of the damage of the non-neural tissues. The most common types of pain, like the injury, like infection. So we know this kind of pain, this is nociceptive and best relieved by morphine, by paracetamol, or different kinds of non-steroidal anti-inflammatory drugs. But the other kind of pain, which is neuropathic, which is because of the damage or dysfunction of the neural tissues, are not relieved significantly by the analgesic drugs. So in this type of pain, we need to give co-analgesics or adjuvant drugs, which are mostly the anticonvulsant drugs and antidepressant drugs. Amongst the anticonvulsant drug, the most common drug is pregabalin and gabapentin. Otherwise, carbamazepine is also another old drug which can also be used in this kind of patient. And amongst the antidepressant drug, the most commonly used drugs are amitriptyline and nortriptyline, and few others like duloxetine is also used to manage the neuropathic pain. There are a few other kinds of adjuvants which is not that commonly used, but as a whole, neuropathic pain are not taken care nicely by the analgesics, but it can be taken care nicely by the adjuvant drugs or co-analgesic drugs. So here in this patient, we had the leg pain which was neuropathic in nature, as diagnosed by the pain detector tool. We know that neuropathic pain is difficult to diagnose, and there the questionnaires, the history is very important. We have certain bedside tools based on the questionnaires with which we can make a diagnosis of neuropathic pain. Like in this patient, we used pain detector tool. Pain detector tool, if the score is 12 or less, it is called nociceptive. If the score is more than 18, it is neuropathic. In this patient, the leg pain detector tool score was 19 out of 38, which clearly signifies that this is a neuropathic pain, and that's why this pain was managed nicely by the pregabalin and nortriptyline. Whereas the back pain, which was significantly nociceptive pain, was nicely managed with the intrathecal pump. Intrathecal pump, we used morphine. We know that the intrathecal morphine is 300 times more potent than the oral morphine. So 1 milligram morphine intrathecally was enough to manage this patient's back pain. So to summarize, whatever pain we see can be either nociceptive or neuropathic or a mixed varieties. Based on our clinical assessment with certain kind of tools, we can judiciously use the analgesics or co-analgesic drugs, and sometimes the combination of this patient. So this was an ideal patient where we have used both morphine to take care of the nociceptive pain as well as the adjuvant drugs to take care of the neuropathic pain. So the cancer pain, like other chronic benign pain, are managed in a similar way by assessing the patient's character of the pain, whether it's nociceptive or neuropathic. We can use the drug judiciously and give a significant pain relief to our patients. Thank you.